I am going to get it going here to announce our next speaker, Dr. Anthony B. Iton. He's a Senior Vice President of Healthy Communities at the California Endowment, the state's largest private health foundation. His primary focus is on the foundation's 10-year Building Healthy Communities, California Living 2.0 initiative, the goal of which is to create communities where children are healthy, safe, and ready to learn. Prior to his appointment at the endowment, Iton served as both the director and county health officer for the Alameda County Public Health Department. In that role, he oversaw the creation of an innovative public health practice designed to eliminate health disparities by tackling the root causes of poor health that limit quality of life and lifespan in many of California's low-income communities. For 3 years, Iton also served as Director of Health and Human Services and School Medical Advisor for the city of Stamford, Connecticut. Concurrent to that, he also served as a physician in internal medicine for Stamford Hospital's HIV clinic. In addition, Iton served for 5 years as a primary care physician for the SF Department of Public Health, where I am soon to be an employee. Iton's varied career also includes past service as a staff attorney and health policy analyst for the West Coast Regional Office of Consumers Union, the publisher of Consumer Reports magazine. Published in numerous public health and medical publications, Iton is a regular public lecturer and keynote speaker at conferences across the nation. He earned his BS in neurophysiology with honors from McGill University, his JD at the University of California, Berkeley Bolt Hall School of Law, and his medical degree from Johns Hopkins University School of Medicine. Welcome, Dr. Iton.
Great. Well, thanks for having me back, I guess. I don't like these Zoom things really at all. I like seeing people's faces. I like interacting with people. This feels very artificial, particularly as like literally all of you have your cameras turned off. So I don't even know if you're there. So I encourage you to sort of engage. This is kind of boring for me if I'm not interacting with people. And I don't like to be bored. But anyhow, I think you'll enjoy this, and I think that you'll want to interact. All right, so I'm going to share my screen, and hopefully that will work. And I'll need a thumbs up that okay, great. All right, so I'm going to jump right into this and assume that there are actually human beings on the other end of this other than Kelly and Reese. This is probably going to be amongst the most unusual talks about health that you've ever heard. And it's designed to sort of provoke you a little bit and get you thinking about things that you already know. But in medical school and in residency, people will try to train some of this intuitive thinking out of you. And I want you to hang on to it because it actually is what makes the difference in terms of health. And so it's called Tackling the Root Causes of Health Inequity, but think of it as what really creates health in an individual, in a community. And think about what you know about that. If you had to answer that question, what would you describe as the sort of critical ingredients for health? All right, so I want to jump in and remind us all of Rudolf Virchow, who you've probably studied in pathology. In my day, we had a big Virchow's textbook of pathology and pathophysiology. But Virchow was also one of the first social epidemiologists. He wasn't the first, but he was an observer of the human condition, not just the diseased organs. And he had the ability to sort of look at the structure of society and relate the structure of society to the actual diseases that befell that society. And he says famously that physicians are the natural attorneys of the poor and social problems fall to a large extent within their jurisdiction, meaning that physicians are more than just mechanics. They're also kind of reporters on the effects of society on human health. Okay, so I'm a lawyer as well as a doctor. So one of the things that I was taught in law school is always state your conclusions up front, because you never know when you're going to be interrupted by a judge or somebody objecting to whatever you're saying. So you want to get your conclusions out there. And that turns out to be a pretty good way in public health to manufacture sound bites. And sound bites are important in public health because you're often there with like in COVID-19, you're there as a health director or physician and somebody sticks a microphone in front of your face and says, Dr. Iton, what is it that the public needs to know? And so the conclusions I'm going to offer you right now are actually false conclusions. One of them is that health is behavioral. And this notion that people who smoke and drink and drive without a seatbelt, have sex without condoms, really are sort of behaving badly and are bringing on poor health conditions onto themselves. Another one is that health is transactional. And this one is very dominant. The idea that the quality of healthcare, the quantity of healthcare, the access to pharmaceutical drugs, all of that really dictates health. The idea that medical services and intensifying the frequency and quantity of those services is really the solution to generate health. And the third is that health is genetic, that it's basically a lottery. And there are people with good genes, those with bad genes, and the ones with bad genes are unfortunate, and our goal is to sort of manage the physiological consequences of them having these bad genes. And I want to argue to you that these are all individual frames. They're not actually macro frames. They're looking at the world as a collection of billions of individuals and trying to understand sort of a larger health phenomenon through aggregating the individual health phenomenon that we witness in a clinical encounter. And so they're not wrong at the individual level, but they are wrong at the societal level. I want to argue to you that at the societal level, the primary determinant of health is political. And I intentionally make the P a small p because we're not talking about partisan politics, Democrats, Republicans. We're talking about a definition of politics, which is the struggle over the allocation of limited and precious social goods. And those limited and precious social goods may be things like having a park in your neighborhood, or a sidewalk, or a grocery store. These are health protective amenities that are allocated in a political process. And those communities that lack political power struggle to get an adequate or even equitable allocation of those health protective resources. So if health is political at sort of the societal level, that means that power matters: political power, social power, economic power at the individual, family, and community levels. Okay, another conclusion, and this one is real: health is not healthcare. And I think most of you know that. Healthcare is responsible for somewhere around 10 to 15% of health status. Where you live matters, and it matters a lot. And I'm going to prove that to you, or at least try to prove it to you. And then finally, health is an investment. It is not an expenditure. Healthcare is an expenditure. Health is an investment. If you invest in health, you reduce the expenditures associated with medical care. And so when we talk about, health being expensive and we have to reduce the cost of health, what we're talking about is reducing the cost of downstream medical care because we haven't invested upstream in health. And we can see that by looking at countries that have strong, what are called social contracts or compacts. And those social contracts, I'll give you an example of one in a minute. Those countries that have invested more in the health of their populations through having strong social contracts have better health. Okay, but I want to start, and I'm going to engage you because I just have to. And unfortunately for Jenny Ventura, you're the only person I can see other than Kelly and Reese. So I'm going to ask you, Jenny, to unmute yourself and read this out loud to everybody.
I will say then that I am not, nor ever have been, in favor of bringing about in any way the social and political equality of the white and Black races. That I am not, nor ever have been, in favor of making voters or jurors of Negroes, nor of qualifying them to hold office, nor to intermarry with white people. And I will say in addition to this that there is a physical difference between the white and the Black races, which I believe will forever forbid the two races living together on terms of social and political equality. And inasmuch as they cannot so live, while they do remain together, there must be the position of superior and inferior. And I, as much as any other man, am in favor of having the superior position assigned to the white race.
Thank you, Jenny. That was awesome. Jenny, do you happen to know who said that? Who's famous for that quote?
I don't know who said it.
Okay, does anybody know? Just unmute yourself and just say it if you know.
Yale Abe Lincoln.
What's that?
Yale Abe Lincoln.
Who's saying that?
That's Kelly saying that.
Why would you say that, Kelly? That's, I hate to say it, but that's kind of a stupid answer.
Because the belief that some of our biggest champions for racial equity and equality were not racist is false. And if your first conclusions or your first points made really surrounded about the fact that we in America, or at least a lot of people, believe that healthcare is an economic argument rather than a rights argument. And it makes a lot of sense why someone who morally did not necessarily see the benefit of ending slavery, but financially might have, would issue a statement like this.
Wow, that's actually right. So I was just kidding. That was not a stupid answer. That was a very good answer. That was Abraham Lincoln. And Abraham Lincoln was a white supremacist. He actually did eventually come to believe that slavery was not something that should be continued. And when he was making the argument that Kelly or Jenny just read, he was in a debate with William Douglas in 1858. He was running for the Senate in Illinois, and he was trying to distinguish himself as somebody who was against slavery, but pro-white supremacy. He was basically saying, whoa, 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 I may be anti-slavery, but I ain't saying that blacks and whites are equal. Don't get me wrong. And that's what that speech was about. And he goes on to say, and you've been to the Lincoln Memorial, you've read the Gettysburg Address, the second inaugural address, but he goes on to say, our Republican system was meant for a homogeneous people. As long as blacks continue to live with the whites, they constitute a threat to the national life. Family life may also collapse, and the increase of mixed breed bastards may someday challenge the supremacy of the white man. So this was Abraham Lincoln literally saying, I'm a white supremacist, vote for me. I want to ask, why do we not see these words carved into marble at the Lincoln Memorial? I mean, you've all been there, you see the big statue of Lincoln, and then you go to the left or the right and you see these words carved into marble, and we all, like, grab our hearts and, salute the flag. But you don't see this carved into marble at the Lincoln Memorial. But he said this, and he said this quite actively. He said this in search of votes, when he was running for Senate. I'm going to ask, one or two people to opine as to why we don't see these words celebrated of Abraham Lincoln.
I feel like we need our heroes, and this makes him less of a hero.
Kelly's doing all the work here. All right, people, I've told you, I need you to participate. Otherwise, I might go to sleep.
Yeah, I was going to add that that I think it's just, as a society, sometimes unfortunately so painful to pay attention to the darker side of these things, and it's easier to just literally whitewash history or view it from one side, which is not the right answer, but seems like something we've done for a while.
Yeah, who is that? I can't see you, so.
Joanna.
Thanks. Yeah, I think that was a great observation. I mean, we construct a narrative about who people were. We have heroes and icons, and we try to essentially cement their legacy in a way that's consistent with that narrative. So America is a land of the free, and Abraham Lincoln is the great emancipator, and the Republican Party is the party of Lincoln. They embrace those values that they want to associate with the man, but they ignore those things that are overt. These are not quietly whispered things. These were public speeches that are celebrated as profound speeches, by historians. We don't talk about that legacy of Lincoln because we have a narrative, a story that we want to tell ourselves about who we are as Americans. And I want you to just hang on to that idea of the power of narrative, because I'm going to try to drill home to you how critical narrative is to health. So starting with this, there are basically only two narratives in the United States, and actually, quite frankly, in most countries. And the narratives are, I'm depicting them here as sort of a dark narrative and a sort of a bright narrative. Maybe oversimplifying, but the narratives are basically about exclusion and inclusion. Who is really kind of deserving of the full fruits of the society? That's what the narrative battle is. And that narrative battle shapes policy. The winner of that narrative battle gets to construct the policy. And the policy creates the conditions, particularly for things like health, but also in education and employment and tax policy. They're all driven by a narrative. And that's how essentially advocacy works in the public sphere. People actually tie their policy ideas to a narrative. And through tying the policy idea to a narrative, if they win the narrative battle, they win the policy battle. So let's look at some themes. There are themes running through our society: income inequality, mass incarceration, student protests on campus, international refugee crisis, the Black Lives Matter movement, Moral Mondays in North Carolina, Indigenous people's rights, and Standing Rock. And there's a theme that runs through this, and there are other major themes that are running through our society right now: anti-Asian racism, the undocumented crisis. The theme of exclusion runs through this. Each of these populations that are protesting for essentially rights and to be heard are protesting that they're being excluded. They're being excluded in terms of their way of life. They're being excluded in terms of their interests. They're being excluded from opportunity. The theme of exclusion runs through all of these movements. And the narrative of exclusion, which is what Abraham Lincoln was promulgating. He was saying, look, I may not be pro-slavery, but I'm not pro-equality. And we still don't think Blacks should be jurors or be able to marry white people or, to have meaningful opportunity. That would be crazy, right, people? So the narrative of exclusion does three things. It intentionally dehumanizes the target. Remember, Abraham Lincoln said, I believe there's a physical difference between the white and black races. Our last president, announced his candidacy by claiming that, quote unquote, Mexicans were bringing drugs, they're bringing crime, they're rapists. We've heard talk about takers or welfare queens, crack babies. These are very intentional efforts to dehumanize the target of the narrative. The second thing that a narrative of exclusion does is it exaggerates this notion of scarcity. And it argues that we're basically in a war for resources between competing tribes. And anything that tribe gets means that they have to take it from us. Therefore, we have to deny them as much as we can. And the third thing it does is it looks to the past nostalgically. It talks about, America having been great. It ignores racism, slavery, genocide, the incarceration of Japanese, the exclusion of Chinese, the subjugation of women. And it looks to the future with fear. The past was great, the future is scary. That's what a narrative of exclusion does. Every single narrative of exclusion does these three things. And it does it very, very systematically. Narratives are very, very powerful things. If you look at the people on the left side of this image and what they're doing, charging those fences, attacking the police at the Capitol, waving their flags, they're motivated, they're animated by a narrative, a story of whose country this is, to whom it belongs. And what is happening to them is it's being stolen from them. Just think about that for a second. They're motivated entirely by a story. they're sending this wall, climbing the walls of the Capitol in their minds, thinking, I'm going to take my country back. It's mine. It's nobody else's. Other people have taken it. I am going to take it back. Narratives are extremely powerful. Very simply, when it comes to health, this is Senator Arlen Specter, who died several years ago, but in 2010, he was a Republican senator that was trying to constructively create improvements in our healthcare system, particularly around the Affordable Care Act. And he held a town hall. He and many other senators and congresspeople held town halls around the country, and people showed up with guns to these town halls to essentially say, I don't believe in universal health insurance. I believe that if other people are going to get it, it means they're going to take it from me. That there's a zero sum. There's not enough for them. There's only enough for me. And so in their minds, that narrative that this is mine, I will protect it, I will defend it, I will arm myself to assault anybody who feels that they need to give it to others. Okay, so that was a narrative of exclusion. There's also a narrative of inclusion. As I said, there's only two narratives. It's a pretty simple thing. The narrative of inclusion does almost the exact opposite. It changes the narrator and it lets people tell their own story. And you'll see this now when you watch the anti-Asian violence news reports, or the Derek Chauvin trial, and the various police shootings that have happened. Who's telling the story? And who tells the story changes the entire context of the story, because it allows people to humanize themselves. It allows the viewer to see their own humanity in that person's story, to see the connections between my story as an audience member and the person who's speaking story as an Asian elder who's been attacked in their community when they're going about their daily business. I see their humanity. I recognize how we have a shared humanity. That's critical in a narrative of inclusion. It also broadens the lens and shows how we are mutually interconnected, how our fates are inextricably intertwined. And then finally, it looks to the past realistically. It tells an honest story of where we've been as a country and looks to the future with purpose and hope. So these are the two dueling narratives in the United States, and those narratives control policy.
A question. Do you
Yeah.
think that these narratives fall along party lines in the US?
I think that more or less they have, particularly recently. I don't think that historically it was such a tight concordance between the sort of the party splits. But I think more recently, particularly with the rise of Trumpism, but even before Trump, there was Sarah Palin. There have been some others on the right, Newt Gingrich, others who have essentially made that narrative of exclusion argument very forcefully. But the Trump basically owned it. Like I said, he ascended or descended a golden escalator, and then literally amongst the first words out of his mouth, he accused Mexican Americans of being rapists. And this was the reason that he needed to run for president. So I don't think anybody's ever been as explicit as he was about what his candidacy was about. Okay, we're going to get back to narrative in a bit, but I want to talk about place first, why it matters. And this is where I grew up. Wonderful city with great infrastructure and resources, housing stock, public art, cafes, parks, state-of-the-art public transportation. This is Montreal, Canada. In the foreground is McGill University. In the background is downtown Montreal and the St. Lawrence River. And I grew up in Canada in the 70s and 80s, and Canada has a very strong social contract. I mentioned that I was going to talk about social contracts. It's got universal health insurance for every Canadian, universal dental care for children, universal childcare benefit, universal paid sick leave and vacation, state-of-the-art public transportation in most major cities, highly subsidized post-secondary education. I went to McGill University for free, and I could have gone to McGill Medical School for free. high quality resources, community centers, museums, parks, sports leagues. Canada really invests in its people. And if you're trying to assess the strength of a social contract in a country, just look for one word. And that word is universal. And to the extent that countries have a strong sense of shared solidarity, they will construct universal policies. In other words, they will see their own fates as being intertwined and recognize that my investment in you is an investment in me. And so I decided in the mid-1980s to leave Canada and go to Johns Hopkins Medical School because somebody told me it was the best medical school in the world. I don't know whether that's true or not. But this is what I was confronted with immediately when I landed in Baltimore. These are scenes from immediately adjacent to Johns Hopkins Medical School. And I had never seen anything like this before in my life. And I traveled, don't get me wrong, I'd seen other places, but I thought I was coming to a first world country. And I had no idea that in the United States, you had conditions like this. You don't have these conditions in Canada. You simply don't. I'm going to show you some data comparing the US to Canada a little bit later, but I had never seen anything like this. I was being toured around by an upperclassman and he saw how astonished I was and he said, "What's wrong?" And I said, "Well, when was there a war here?" I had never seen so many burnt out, bombed out looking buildings, garbage piled up to people's knees, rats and mangy dogs wandering around, cars up on stilts, and babies playing in and amongst all of this. And I'll never forget what he said to me. He looked at me with his look of like utter disdain. And he said, "What did you expect? It's the inner city." And I thought, oh my goodness, I was supposed to expect this. And it's got a name, the inner city. And this was a norm for America. And I was the idiot for not understanding that this was normal, that you just have inner cities, they naturally occur. And I couldn't help but ask myself, well, what if I had grown up in East Baltimore instead of in Montreal, Canada? For all intents and purposes, that kid is me. This kid had no hand in creating the conditions in East Baltimore that he has to navigate every single day of his life. No more so than I had any hand in creating the conditions that I grew up in Montreal, Canada. Yet, for all intents and purposes, we're the same person. Would I have been able to go to Johns Hopkins Medical School had I grown up in East Baltimore? And what do we owe this kid in terms of conditions? I mean, what is the obligation to our fellow humans to ensure that conditions in which they are growing up and living allow them to essentially be healthy, to find healthy opportunity, to find healthy resources? And so this was a question for me when I left Baltimore, but it wasn't just Baltimore. Years later, I got involved with an effort to help a community that was really struggling. This is Austin, Indiana. Austin, Indiana is notorious. In 2015, it had the world's highest incidence of HIV/AIDS, higher than sub-Saharan Africa. And this is the middle of the United States. It was in the throes of an opioid epidemic. People were grinding up this drug called Opana and overdosing, sharing needles, and getting HIV and hepatitis C at very high rates. Austin, Indiana is 98% white. And for all intents and purposes, it looked to me like East Baltimore, Maryland. The only difference is that this is really the white and black sides of the coin, the two faces of income inequality in the United States. And what became clear to me is that we manufacture social vulnerability in this country. And whether it's sort of rural poverty or inner city poverty, these two things are policy created. They're not natural. They don't just happen. They happen in the face, in the absence of affirmative policy. They happen in the absence of a social contract. And so, the question for me was, what's the American social contract? I mean, what are the universal policies, investments that all Americans have access to? And how does that impact our health? I would ask you the real question, but I'm going to keep going. So I left Baltimore with this sort of sense of, in the United States, when it comes to your health, does your zip code matter more than your genetic code? And I ultimately ended up getting quoted as having invented this question. I don't know whether I did or not, quite frankly, but people have ascribed it to me. But I had to prove it to myself. I had to understand what was operating at the neighborhood level that was creating health outcomes in these conditions, adverse health outcomes. I ended up in the San Francisco Bay Area. That's San Francisco. I was the health officer and health director for Alameda County, which is that outlying large county, 1.5 million people. It's got the city of Oakland, Berkeley, and 16 other cities. And when you're the health officer, you're the registrar of all births and deaths. And there are about 10,000 deaths in Alameda County every year. And each one has a death certificate on it. And those death certificates have what you died of, your age, your race, ethnicity, and where you lived. And you can take those 4 pieces of data from hundreds of thousands of death certificates. We used about 500,000 of them to construct essentially a story of death in Alameda County. And so we took Alameda County, which is shaped like a boot, and looked at each of the census tracts or neighborhoods within the county. There are about 150 of them with about 10,000 people each. And we calculated on average how long somebody could expect to live in every census tract in the county. And the red neighborhoods are where people could only expect to live to about 74 years. The green, people could expect routinely to live above 80 years, and the yellow are in between 74 and 80. And when you look at this map, the first thing you notice is that there's clustering. There's clustering of those red areas. And those are areas that we ultimately refer to as death zones. Those were areas where essentially there was a cost to living in those communities that could be measured in shortened lives. And they occur in the flatlands of Berkeley, flatlands of Oakland, east and west, and then some of our unincorporated areas along the Interstate 880 corridor. And that map got a lot of attention. It ended up on the front page of the San Francisco Chronicle, stimulated a lot of policy conversation and debate. One of the questions that came up was, is there something wrong with Alameda County? And I had to disprove that. So we took our map and we started to go to health departments around the country. I went back to Baltimore, worked with the Baltimore City Health Department to create a map, and they discovered that they had neighborhoods, including around Johns Hopkins Medical School, where life expectancy was as low as 58 years, and other neighborhoods where life expectancy was approaching 90 years. Similarly, in Cleveland, Cuyahoga County, we had a neighborhood Huff of 61 years life expectancy average, and then Lyndhurst, 1.8 miles down the road, 88.5 years of life expectancy. We found similar phenomena in Denver, in New York City, in Seattle, in Los Angeles, in Minneapolis, St. Paul, Boston, Philadelphia, San Antonio, Chicago, Cincinnati, St. Louis. Everywhere we looked, we found these differences of 12, 15, 20, 25, 30 plus years. This is the American pattern. There's nothing unique about Alameda County in this regard. This is how we stratify opportunity in this country, and it manifests itself in health in very measurable ways. And these are fixed patterns. These are not patterns that jump from year to year. These patterns have been fixed for 20 plus years in many of these cities, and in many instances, they're getting worse. We saw some interesting phenomena. The starkness of this difference is greater on the East Coast than it is on the West Coast. But nowhere where we looked, and we continue to look, I'll show you some data from Canada in a minute, we've not found any place where you don't find these differences, these fixed, embedded, entrenched differences in life expectancy across cities, sometimes with neighboring communities. In places like Detroit, you see a 20-year life expectancy difference between 2 adjacent communities. And if you know anything about the history of Detroit, there's good reason for that. Let me talk you through this quickly, because another way of looking at this data is to essentially do what's called a bivariate analysis. You take life expectancy on one axis and poverty, also from the census, on another axis. So each of these census tracts has a life expectancy number that we calculated from death certificates and a poverty number that's determined through the census. And then you can correlate those two things, which each of those blue dots is a census tract in Alameda County. And so on one axis, on the y-axis, you've got life expectancy going from low to high. And then on the x-axis, you've got poverty, the poverty rate of the neighborhood. Going from left to right, you're going from relatively wealthy neighborhoods to relatively poor neighborhoods. And then you can calculate the slope of that regression line. And in an ideal world, that would be a flat line, right? How poor your neighborhood is wouldn't predict how long you live. But in the real world, there's a slope to that line, and there's a cost to living in a poor neighborhood that can be measured and used to predict how long people will live in their neighborhoods. We started telling people in Alameda County, give me your address, I'll tell you how long you're going to live. And we would be right much more often than we were wrong.
A question that was asked from our audience, Dr. Iton,
Sure.
specifically around, I think in the context of when you're pointing out that like almost adjacent neighborhoods or communities can have such different outcomes. Could those differences, or could that difference in, I'm assuming, life expectancy to this question be because of the stark segregation of communities, especially the difference in East versus West Coast? I'm assuming the question was along the, in the context of race, but can segregation explain any part of this?
Segregation explains almost all of this. This is American apartheid. This is how it manifests itself. Now, you can do this analysis and just control for race. You can just look at African Americans, which we did across the spectrum, look at whites across the spectrum, look at Asians across the spectrum, and you do see differences between neighborhoods. So it's not all racial segregation, but it's mostly racial segregation. So segregation is both economic and racial in this country, and the two things are inextricably intertwined. It's very hard to tease them out, race versus class, because they have served as proxies for one another. The predominant feature of this is race. The race is essentially the operating system for American housing policy, and neighborhoods were constructed around race. And in a longer version of this talk, I go into redlining and racial zoning and the federal policies to segregate people by race. But this is basically segregation, racial and economic. Okay, so we did the same analysis for, and thanks for that question, by the way. We did the same analysis for the San Francisco Bay Area. We did the same thing for California as a whole. This is some data. I'm going to go through this quickly because I want to show you some new data. This is some data doing international comparisons, looking at the United States versus Canada and Australia. These are old data from around the year 2000. And let me just sum it up and say that the blue line is the US cities, and the red line are Canadian cities, and the green line, which is probably faint, you can lean in and see it, are Australian cities. And what this is measuring is essentially income inequality across these various cities and mortality rates. In other words, the more unequally income is distributed, the higher the mortality rate. So that's in essence saying, when you look at American cities, and particularly when you look at places like New Orleans and New York City and Monroe, Louisiana, and even Los Angeles to some extent, you see high levels of income inequality, and that correlates with high levels of death, high levels of mortality. And you see this sort of slope. When you look at the American and our Canadian and Australian cities, you see a much flatter line. You see much less mortality correlating with sort of how income is distributed. And you see much more equitable income distribution because the Canadian and Australian cities are pushed to the right. Okay, well, simpler analysis of that we did somewhat recently. These are California counties, and I'll just read them out to you because the print is really small. Alameda County, Los Angeles County is the orange one. Orange County is the top right. Then we go to Riverside, San Bernardino, San Diego, and then Santa Clara counties. And this is life expectancy versus income. The same graphic that I showed you before of Alameda County and the San Francisco Bay Area. All I want you to take from this is the slope of these respective lines. Just look at the slope. That's the slope of the regression line of this scatter plot. And then we looked at Canadian cities. So here's Calgary, Edmonton, Montreal, Ottawa. There's two sections of Ottawa, the Gatineau region and the Ontario region, Toronto, and then Vancouver. And just look at the slopes of these lines. I'll just go back. These are the California counties. These are the Canadian cities. To make it even clearer for you, here's all of the California counties up in that upper graphic, and there are all the Canadian cities on that lower graphic. And you see the respective slopes of those lines, meaning that as you move from relatively richer to relatively poorer Canadian cities, there's relatively little loss in terms of life expectancy. There is more equity. Whereas when you look at California counties, moving from relatively wealthy communities to relatively poor communities, you see substantial loss in terms of life. And this, I put it to you, is basically the difference in the social contract. There are investments that are made in Canada and in Canadians that buffer against essentially the health injury associated with living in a low-income community. Things like universal health care, universal child care, paid sick leave, paid vacation, universal dental care, housing policies, all kinds of policies that buffer against adversity, even in the face of poverty. The cost of poverty in Canada is cheaper than the cost of poverty in the United States. When you're poor in the United States, you lack access to virtually every critical health protective resource.
Something I'm struggling to rectify though here, Dr. Iton, is the idea that like classism, sexism, racism, they all exist in these other countries too. Like you could argue that there has certainly been an inequitable distribution of resources between Canada's First Nations and Indigenous population and everyone else. You could argue that there's an inequitable distribution of resources between Canada's French population and everyone else. So I'm trying to understand how the state's got in this predicament when it's the same racism, it's the same classism, or is it not?
Well, so that's the question, right? I love the question because it's nuanced. Now, first of all, let me just point to something that you should at least see. So in this graphic, these are the Canadian cities. On the middle row, you see Ottawa, Gatineau, the Ontario part, and then you see Ottawa, Gatineau, the Quebec part. And you see a steeper line in the Quebec part. That touches on the question that you raised about French Canadians. This is the same city, but two different kind of demographics within that city. And you see more of a steep line in the Quebec part of Ottawa than in the Ontario part of Ottawa. And that ties back to the historical segregation of French Canadians. There's a book called White N-Words of America. The N-word is actually not N-word. That's about essentially the French Canadians and many of the same, well, not the same, but the nature of the discrimination towards French Canadians mirrors to some extent discrimination against African Americans. Now the difference though, the overall difference between the US and Canada, and you're asking somebody who's Canadian and grew up in Canada and then lived the other half of his life in the United States, is this policy. US policy, slavery was a policy. The devaluing of African Americans is written into the US Constitution. If you study law and you look at Supreme Court cases on busing, on education, on voting, on citizenship, you see the dehumanization of African Americans, as well as Chinese, Japanese, Latinos, written into US Supreme Court precedent. You don't see that in Canada. There was no slavery in Canada. There was no Jim Crow in Canada. There wasn't racial zoning in Canada. There weren't racially restrictive covenants in Canada. You didn't have a GI Bill that discriminated against people, veterans based on their race in Canada. So Canada has, and I'm not saying Canada's a perfect place. I mean, we could have done this, as a matter of fact, we are doing this analysis with New Zealand and Australia and Norway and France. what there is a sense of shared solidarity between people, and that allows you to construct universal policies. And what the United States does not have is shared solidarity, and therefore lacks universal policies. Universal policies are what essentially construct your social contract. And the US has practically the absence of a social contract. All right, let me keep charging through this. So, you know, you can't really, part of my job is to tell people this stuff. And we tell people this stuff oftentimes through the newspaper. And you can't put on the front page of the newspaper a scattergram with a regression line with you know, an R squared. But you can monetize the slope of that line and translate it into every additional $12,500 in household income buys you a year of life in the San Francisco Bay Area. That's a headline. It was a headline. And it has dramatic policy implications for people to understand how life is essentially priced in the San Francisco Bay Area. So that's what we do. We spend a lot of time sort of using real zip codes, real life expectancies, and we showcase this. You know, one of the things that I often get, I used to get it a lot more often, I think that the, you know, the police killings and Hurricane Katrina changed people's understanding of some of these concepts for the better. But I used to get, particularly from doctors, I remember being at Stanford one time and doing a presentation, and a Stanford surgeon came up to me afterwards and said, "Hey, Tony, you seem like a really nice guy, but you know, you're Canadian, and so you don't really understand America." And the reality is that America is an incredibly generous country that invites all of these immigrants from all over the world. And it's the immigrants that come here and they bring down our health statistics because they're sick. And we put them in our hospitals and we treat them and they get better and then they get healthy as us. If you want to see how healthy America is, just look at white people. White people are the healthiest population on the face of the planet. This was a Stanford surgeon. And I said, wow, okay, that probably isn't true. So let me look at the data. You know, of course, I like to look at American health overall. I don't necessarily like just looking at specific populations. And American health overall is not good. It is not good. And this is Time Magazine doing me the favor of telling America, America's health is not good. Let's look at the data. So we know on per capita basis, the US spends more money on medical care than anybody else in the world. We spend roughly twice what other developed countries spend. Everybody knows that. And we know that we don't get great results for that. But if you take that same data and you just sort of reorganize it a little bit, now the blue is the same thing as what I just showed you. So this is per capita spending on medical care. The blue is now per capita spending on medical care, but added to it is per capita spending on social benefits and services. And just think of the red as the social contract, what these respective countries are investing on a per capita basis in social benefits and services. And so when you do that, you add per capita spending on medical care to per capita spending on social benefits. Now the US is not the big spender. We're actually kind of comfortably in the middle of the pack of other developed countries. Our challenge is that our spending is skewed towards medical care and away from social benefits. Well, this was a study done by these two women, Elizabeth Bradley and Lauren Taylor, who wrote a book as a result of that study called The American Healthcare Paradox. This is their TED Talk. And they showed that essentially in other developed countries, the so-called OECD countries, for every dollar spent on healthcare, roughly twice as much is spent on social services, $2 on social services and benefits. And this is a list of the kind of benefits that those countries invest in. In the United States, on the right side of this graphic, for every dollar on healthcare, we spend only about 55 cents on social services and benefits. So we literally have the accent on the wrong syllable. And they showed that the ratio that really is most associated with good health is 2 to 1, social benefits to medical care. So if you want better health, spend more on social services. I'll say that again. If you want better health in a population, invest in social benefits and services at literally twice the rate you're investing in medical care. Bradley and Taylor's study was replicated by RAND, for a variety of reasons, amongst which they are two women in a man's world of health services research. And the men who had been studying this for 40 years just didn't believe them. So they asked RAND to replicate the study, and RAND did, and used more countries, including using every single state in the United States. And RAND concluded that not only were Bradley and Taylor right, they were actually even more right than they thought they were. And this is just one of the graphics from the RAND study. If you look at you're looking from 1980 to 2010, if you look at the dark orange and the dark blue lines, those are social spending in the EU in the orange, and social spending in the US. And you see over that 30-year period, a sort of a fixed gap between the proportion of spending, social spending in the US compared to the European Union. If you look at the sort of the faint orange and blue lines, that's life expectancy at birth from 1980 to 2010. You see that in 1980, US and EU life expectancy were roughly the same. And over that 30-year period, you see this steady gap as the EU pulls away from the United States. And then you look at the dotted line, that's health spending from 1980 to 2010. You see that they start at roughly the same level. And then US health spending pulls away from the EU over that 30-year period. And so RAND concluded that higher levels of social spending are strongly associated with better health. That's what Bradley and Taylor found as well. If you want better health, spend more on social services and benefits. They further went on to say that the association is particularly strong for public, i.e. government spending, as opposed to private social spending. The association between social spending and health outcomes is strongest where income inequality is greatest. In other words, those countries with the greatest income inequality actually benefit the most from social spending. And finally, these observations were observed across even individual states within the United States. The states that spend more on social benefits and services have better health.
So a question that was brought up in response to this, if you were to make these statements that spending more on social services is in fact beneficial, and here's the data, a majority of Americans would probably express some sort of resistance to that concept. But a lot of people do understand this as fact, including policymakers. So why haven't we incorporated this ideology into our country's policy decision-making process or healthcare infrastructure decision-making process? If we understand this to be fact, and RAND is a pretty reputable firm, right? So like, why? I think there's actually two questions in Rachel's statement. First, where does that resistance or hesitation to accepting this as fact come from? And then two, why haven't we accepted this as fact and leveraged it in policymaking discussions?
Rachel, you're rational like I am. The problem with being rational about this is that it's not rational. So two basic points. One is that how we decide how to apportion our spending in terms of medical care versus social services and benefits is through a political process. And in our political process, we allow for profit-seeking entities to have substantial political power. I do another talk where I talk about the Affordable Care Act and sort of the history of the Affordable Care Act and how it came to be. And one of the things that the Affordable Care Act process showed us was that Barack Obama, learning the lessons from the Clintons, decided he didn't want to make the same mistakes that they made. And so before even sort of introducing the concept of, health reform legislation, he had his administration go and cut deals with various different industry sectors. They cut deals with the pharmaceuticals, they cut deals with the insurance industry, they cut deals with the medical device manufacturers, they cut deals with employers, they cut deals with the unions. And once they had all those deals cut, they had this very narrow pathway to legislation for the Affordable Care Act. In those deals, they basically said, we're not going to do single payer, we're going to have a minimal government presence, we're not going to touch the union benefits, we're not going to regulate drug pricing, we're not going to regulate pharmaceutical manufacturing pricing, we're not going to cut insurers out. So what was left is the ACA. And no other country in the world legislates like that. you don't start by going to the people who stand the most to benefit from the status quo and ask them what they want out of reform. But in the United States, that's what we do. And so as a consequence, rather than having Medicare for all, we have the Affordable Care Act, which I'm not bashing the Affordable Care Act. I'm not saying it's nothing. It just isn't what Americans would have designed had they been given a blank sheet of paper and an opportunity through a democratic process to construct a national healthcare system. It is not. As a consequence, there's no country in the world that has a system like this. And so part of our problem, Rachel, for you and I who are rational people, is that our process is not rational. Our process is essentially, we conflate our political system with our economic system. We believe that our political system is capitalism, which is not only flawed, it's actually historically terribly flawed. The word capitalism doesn't even show up in the Constitution, not once. Yet if you ask most Americans, what's our political system? They'll tell you capitalism. Capitalism is not a political system, it's an economic system. A political system is supposed to put checks on the economic system, and that's what you have in other countries. And therefore, you can have legislation that's designed to essentially benefit the entire population and not first benefit the profit-seeking industry sectors that have enormous political influence and the ability, as they did in the Clintons' case, to essentially throw a wrench into the policymaking process that would have yielded universal health insurance.
Well, in hearing that, couldn't you argue then that America absolutely does have a social contract? It's just that its social contract is capitalism.
That's not a social contract. I mean, by definition. And that may be a capitalistic contract, but it's not a social contract. And, you know, again, not to go too far into history here, but if you read the Declaration of Independence, the Declaration of Independence is the quintessential social contract. The concept of the social contract comes from continental philosophers, mostly John Locke, but some others, Rousseau and others. And the basic idea behind a social contract is that it's government by consent. Is that people relinquish their powers to the government in exchange for an agreement that the government will govern in their best interests. But the people retain the ability to change their minds. In other words, we consent to be governed by our government. But at such a time as government stops governing in our interest, we reserve the right to overthrow that government. If you read the Declaration of Independence, that's what it says. It says we won't be governed by kings and monarchies, we'll be governed by ourselves, but only to the point to which we give consent. And the minute that we stop giving consent, we no longer respect this government. And that's what a social contract is. It's like, do things in our interest and we won't overthrow you. And so in this country, you could argue that it's time for us to overthrow the government. I mean, I'm not arguing to pull a January 6th thing. All I'm saying is that you could make the argument that the Declaration of Independence social contract has been violated. It's been abrogated by corporations. That's good, getting kind of out there, but I'm just pointing out that social contract is as American as apple pie. Okay. So I told you the Stanford surgeon told me that I got it all wrong and I have to look at white people. So I did. And US white life expectancy, and this is actually generous. This is going back a few years. It's actually dropped over the past few years. US white life expectancy is about 79 years. It's 78.6. It's about the same life expectancy as Costa Rica. But US whites are living shorter lives than Belgium, Chile, Denmark, Lebanon, Slovenia, Austria, Finland, Germany, Greece, Ireland, Malta, Netherlands, Portugal, the UK, of course, Canada, Cyprus, France, Iceland, Israel, South Korea, Luxembourg, Monaco, New Zealand, Norway, Sweden, Andorra, Australia, Italy, San Marino, Singapore, Spain, Switzerland, and Japan. There are 33 countries in the world with longer life expectancies than the US. Longer life expectancies than white people in the US. In 1990, there were only 17 countries that had longer life expectancies than white Americans. US white life expectancy is in free fall. It's actually so bad that many health disparities researchers don't even use whites as a benchmark anymore. It's just too low a number. You're better off using immigrant Latinos or immigrant Asians or immigrant anybody for that matter, immigrant Africans. Every immigrant group has better health status than their native born peers. And then as they acculturate, their health actually gets worse. America is not good for your health. If you want to find the healthiest population in America, look at immigrants. They're the longest living, healthiest population until they become Americanized. Don't believe me. Read it for yourself. Read it, the Institute of Medicine or the National Academies of Medicine that published this report a few years back called Shorter Lives, Poorer Health. And this is their conclusion. The panel was struck by the gravity of its findings. For many years, Americans have been dying at younger ages than people in almost all other high income countries. This disadvantage has been getting worse for 3 decades, especially among women. They go on to say the US health disadvantage cannot be fully explained by health disparities that exist among people who are uninsured or poor, as important as these issues are. So that's what the Stanford surgeon was saying to me, that basically this is all about health disparities. It's not about the underlying white population. But the National Academies of Medicine says several studies are now suggesting that even advantaged Americans, those who are white, insured, college educated, or upper income, are in worse health than similar individuals in other countries. Let me ask Kelly, how many of this group actually knew this fact? And if you didn't know it, are you surprised by it?
Yeah, show of hands, maybe a yes or no, or a drop in the chat. Was this new to you? The idea that white Americans are actually performing, you know, not as well as other developed nations, or did we, because we often use whiteness as the standard of excellence, right? You know, blacks are more likely to die than whites, right? So I wonder, is this new to folks? A first comment that it's not new. A personal comment, yes, it was. Okay, split so far. Unfortunately, no, this was not a new thing to learn. Okay. The idea that like we always knew that Americans did poorer. We knew we weren't healthy if you had to compare us, but maybe in the context of whiteness, that might have been new. Not new. Okay.
All right. Okay, well, so a sophisticated crew here. Let me keep going. So this is PBS asking the question, why are so many white Americans dying young? Here's the Wall Street Journal lamenting the decline in life expectancy for white women in the US. This is an article talking about deaths of despair, which is a concept that was first kind of popularized by 2 economists, Angus Deaton and Ann Case at Princeton. Angus Deaton won the Nobel Prize for Economics in 2015. Their studies produced this graphic, among others. And these are mortality rates from 1990 to 2010. And these mortality rates you want to see declining. That's normal. Over time, mortality rates go down with various different populations. That red thick line up at the top is US whites. One of the few populations in the world that over this period of time did not show a decline in mortality rates. In fact, arguably showed an increase in mortality rates, which is typically quite unprecedented. And they coined this term deaths of despair. They wrote a book about it. Overall, US life expectancy has fallen 3 out of the past 4 years. It'll fall again 4 out of the past 5 years because of COVID-19. It'll fall dramatically. It may fall by as much as 1.5 years, possibly even 2 years. Even Sanjay Gupta is talking about this, the decline of US overall mortality driven by stress. As I said, these are messages that we spent a lot of time sort of sharing with the world. And the core concept is that 80+% of what influences your life expectancy has nothing to do with doctors. Sorry, I'm just going to lay that on you. As a doctor myself, it's a little hard to take to know that, but it's true. We're largely irrelevant when it comes to population health. Not entirely, but largely. Why? Because what actually drives health is policy. And policy can either create stress in people's lives or reduce stress in people's lives. And stress is the ultimate common pathway for how essentially the outside world, the environment, gets under the skin and changes your physiology. We all have stressors in our lives. The person who doesn't have stress is dead. So as long as you're alive, you're going to have stress. It may be commuting, it may be housing unaffordability, it may be being socially isolated, it may be being exposed to racism, it may be so-called high demand, low control jobs, which every medical student and intern and resident knows about. It may be a lack of access to critical amenities or experiencing crime. We perceive the stressor through our hypothalamus, sends a message to the pituitary gland, which sends a message to the adrenals, which release a cascade of hormones, amongst which is cortisol. And in the acute phase, cortisol is good for you. When you're acutely stressed, it increases your cardiac output. It rallies glucose for your muscles in case you have to flee or fight. It enhances your immune functions, turns down inflammation, and it stimulates the growth of neurons in your hippocampus and prefrontal cortex, which are critical for what's called executive function, and also critical for short-term memories. When you're constantly exposed to cortisol, in other words, when you're living in a fog of chronic stress, in a community where potable water may be difficult to find, there are no sidewalks, there's no healthy food, you've got fast food and liquor stores all over the place. You may have poor housing stock that's unaffordable, it's crowded. You may not have access to public transportation to get to work. The nature of work may be high demand, low control jobs that pay very poorly. You're basically constantly sort of surrounded by stress, worried about your children, their ability to sort of dodge crime and or gangs, their inability to find safe places to recreate. So now you're living in the red and you're stressed out 24/7. And cortisol, when it's constantly circulating, causes hypertension and cardiovascular disease independent of your diet. Although it has the double whammy of stimulating cravings for high fat, high salt, high sugar foods. So you're sort of doubly whacked by chronic cortisol circulation. It causes glucose intolerance and insulin resistance, which of course can lead to type 2 diabetes. It stimulates inflammation, turns down your immunity, and it causes atrophy and cell death in that same part of the brain that I told you was critical for executive function. So people living in those neighborhoods I showed you on those maps are physiologically changed from living in those neighborhoods. Their physiology is perturbed by the lack of a social contract, the lack of those universal policies that would invest in their opportunity structure changes their physiology. And that physiology promotes chronic disease and premature death. You can say something, Kelly?
I just want to add a comment about the fact that there's like this newly coined term around racial stress, and much of what's been exhibited here in the blue column around like stress, some of those stressors can come upon us by just being Black in America. And like to Jenny's point, Jenny made a point earlier that was new to me, that immigrants have better health until Americanized. And some of that can actually be explained by this concept of existing within the racialized stress in the United States. And so just like we were highlighting that zip code, and then with the sprinkling of like the historical segregation, redlining, et cetera, can affect your life expectancy, as can your existence and moving through society as a minoritized person. And much of what you see in terms of the stressed out state in hypertension, cardiovascular disease, a higher incidence of diabetes, et cetera, et cetera, et cetera, et cetera, can also be explained in part, not only just by zip code, but by race itself and your identity moving through the United States as a minoritized person.
Yeah, and you'll see at the end of this, we have a framework for this which addresses those issues, that it's not just place. It may be job category, it may be, just sort of your status as an immigrant, with documentation issues where you're constantly under stress because you're literally being, pursued by the state in ways that can not only adversely affect your economic well-being, but your physical well-being and health. So there are many ways in which exclusion is manifest. And, you know, racial segregation has been the sort of the dominant operating system and paradigm, but there are other paradigms as well.
Another outcome that I think Rachel wanted to add to this stressed out list is in the context of maternal and child health, how you can see how this physiological change could also contribute to why Black and Indigenous women die at 2 to 3 times the rate than white people, to be clear, because of this stress. Dorothy offered a comment here that we just went over this in class, but one of the major things that leads to decline of health in immigrant individuals are the loss of social support. Immigrant families often support one another, but low wages undermine their ability to do so over time. Ifioma asked the question, do you or anyone have a good epigenetic study to reference in relation to some of these racial disparities or some of the kind of stressed out disparities in terms of how it's affected physiological health? Is there anything around epigenetics that you can add to this discussion, Dr. Iton?
Yeah, I was just about to address a couple of these points. One, on the epigenetics front, you know, we know that chronic cortisol secretion and allostatic load has epigenetic consequences. That some of these chromosomal changes can actually be passed on to children. And there are a couple of researchers who've done a lot of work in this. I can send people references if they want. There's a University of Michigan researcher whose name is escaping me right now that I will come up with probably before the end of this talk, who's done a bit of research in this. And there's another group at Mount Sinai in New York that's done quite a bit of work. In fact, they've asked me to fund some of it on sort of epigenetic changes in populations as a result of allostatic load. So yes, and then on the immigrant front, we actually did contribute to a documentary called Unnatural Causes, which has a full 30-minute segment looking at essentially the so-called immigrant health paradox. Now, immigrants are healthier when they arrive and get sicker as they acculturate as a result of the loss of many of these protective barriers, such as tight social networks, you know, sort of native foods, and then ultimately experiencing racism and discrimination.
Rachel asked, is it Geronimus?
Yes, Arlene Geronimus at the University of Michigan, yeah. Yeah, so, and she's a really nice person. I mean, you know, you could just email her and talk to her about some of these things. Okay, so let me keep going. I want to offer this framework that has helped many people who do this as a practice sort of understand how to organize their thinking. And this is, it's called the Baha'i Framework. A number of us created this 15 or 20 years ago. And it starts with the medical model. And it's basically a series of 6 boxes. These are the first 3 boxes, which basically you read this kind of like Hebrew from right to left. Starts with mortality. And when you see high rates of mortality, you have to ask yourself, well, what's driving that? And you recognize that high rates of morbidity, disease and injury are essentially driving high rates of mortality. And that morbidity is in the form of chronic disease, infectious disease, and injury. And then you ask yourself, well, why are some populations experiencing higher rates of morbidity? You're forced to conclude that this is all about risk, and typically in terms of risk factors and so-called risk behaviors. And this is the medical model, which basically is sort of the tools you have at your disposal in the medical model are individual health knowledge, trying to change what people know and do, typically with brochures and pamphlets or sort of conversations and 15-minute bursts in a cubicle. Access to healthcare, where you're essentially trying to manage the sort of the kind of physiologic consequences of chronic disease, typically with chemicals, with pharmaceutical chemicals to try to intervene in the way the physiology is operating. And then, you know, we tinker with people's genes at great expense, generally with limited results, although probably getting a little bit better. And that's a close to $4 trillion enterprise, this entire medical model box. And it's necessary, it's just not sufficient. What we know is that upstream, there are a whole host of opportunities to intervene. And this is when I talk about healthcare as an expenditure, that's the downstream stuff in the red box. Upstream, you have investment opportunities. And they manifest themselves typically in these other three boxes. And starting again from the right to the left, looking at social inequities, I mentioned place, neighborhoods, as a result of racial and economic segregation. But it's also workplace conditions. It's also status. Status as an immigrant, status as a disabled person, status as an LGBTQ person. There are inequities that manifest themselves in people's lives and shape essentially their risk, create stressors for them that put them at higher risk of illness. And well, what's driving those stressors? Well, if you move up one box to institutional power, you're talking about policies, and both government policies and private policies, corporate policies that essentially skew resources. The most easy one to think about is where do hospitals decide to situate themselves? Where there's the greatest need for healthcare services? No. Where's the greatest ability to pay for healthcare services is where they situate themselves. So you see this rush of hospitals to communities that are well insured and away from communities that actually have a need for medical care. That's another example of sort of corporate policy shaping essentially risk and sort of the conditions that people find themselves in certain neighborhoods or in certain populations. So you ask yourself, okay, well, institutional power or the policies, what is creating those? And that takes you back to the very beginning of this talk with Abraham Lincoln. And that is a narrative. It's a story about who we are as America and who belongs, who deserves, who's in, who's out. And based on that narrative, policies are created in the second box. Those policies then create conditions, which is in the third box. And so that's how this framework works. And when you're looking at health disparities, you're looking downstream. When you're looking at health inequities, you're looking upstream. You can take the word health out and just talk about inequities producing disparities. Or you can be simple-minded like me and talk about conditions creating consequences. And we spend $4 trillion managing consequences a year. Sometimes I refer to it as damage control. And that's what we doctors do for the most part. Not exclusively. I mean, there are all kinds of things we do that are incredible and heroic and cutting edge. But a lot of what we do is essentially manage the consequences of upstream inequity. The downstream consequences are not just in healthcare. You see them in educational outcomes and a whole host of other outcomes. What we've argued is while you have to spend time downstream managing the consequences, we also have to figure out how to focus upstream. And we've simplified our upstream approach into three basic categories: narrative, policy, and place. Place is really as sort of a synonymous with conditions. The place typically is the way a lot of these conditions cumulatively and synergistically interact in neighborhoods to essentially deny people meaningful opportunity. But it's not just in place, as was mentioned before. Certain populations that are not geographically co-situated experience these inequities as well. So this is the basic formula that power matters. In order to hold policymakers accountable for equitable allocation of resources, we have to build political power amongst people who are most impacted by the inequity. And this is why, in essence, the quality of our democracy shapes the quality of our health. And that's the bottom line. If you want better health, you need an effective operational democracy, which can hold institutions accountable for equity. What we got out of the Affordable Care Act, as the example I gave you, and I could give you probably 50 other examples, is not the product of an equitable democratic process. It's the product of a political system that is beholden to profit-seeking, interested corporate entities that have enormous political influence over our democratic system. Okay, healthcare costs live downstream, health lives upstream, expenditures, investments. The name of the game is bringing those expenditures back up upstream, similar to other developed countries that have built out their social benefit structure, their social services structure, and reduced their downstream healthcare costs. So let me stop there. I think I'd like to stop there. Yeah, let me stop there in time for some questions. This is just some stuff about policy violence, and which is a concept which I think is at the heart of the
think we might have lost you for a second, but
Okay, am I still there?
I can hear you.
All right, yeah, I stopped sharing my screen. So I'm happy to take any questions.
So an earlier question I think we can just come back to. Sonia, Sanaya, I'm not completely sure how to pronounce your name, and correct me. You do.
Sonia.
Sonia, okay. Well, go ahead and ask your question if you'd like to. Please do.
Yeah, mine kind of was, I think you made a lot of really valid points about how the Affordable Health Care Act was really skewed towards interests, not towards the community. And so my kind of question was like, considering that and considering our history, it's like, how do you see the US healthcare system changing, if at all, or at least like, do you see universal healthcare being a possible system in our future?
Well, I think that there are two forces that will help drive it in that direction. One is that the Affordable Health Care Act, while it increased access to healthcare, which is good, it didn't do much to control costs. And so the cost spiral is still kind of a driver. We're still too expensive. It still is forcing too much of our gross domestic product to be committed to healthcare. So that's a force that's pushing for simplification of the healthcare system. But the second one is looking at states like California, where the democracy is just in better shape. And in places like California, you're seeing movements now. I mean, we cover undocumented children, we cover undocumented young people up to 26. We're pushing to cover undocumented seniors and ultimately all undocumented people. California is pushing further and faster for universal health care than other states are. There's a significant single payer movement. The Biden administration may facilitate states looking at public options, where the state can offer basically, its own kind of Kaiser plan to compete with some of the private sector plans. So there are forces operating that will continue to correct against our healthcare insurance fragmented system, but the politics at the national level are not helpful, or at least they're more helpful than they were a few months ago, but they're still not terribly helpful.
Thank you.
Do you think there's hope for us to ever actually develop a social contract?
Oh yeah, yeah. No, I think that the answer is sort of the same that I just said. I mean, universal healthcare is sort of the central tenet of virtually every country's social contract. So getting to universal healthcare is the same route towards rebuilding our social contract. There are other aspects. There's paid leave, there's childcare, there's dismantling mass incarceration, enhancing access to the ballot box. I mean, there's a whole host of other policies related to that, housing policies, to look at housing as a right as opposed to a privilege of wealth. But universal health care is the central tenet of virtually every country's social contract. And so if we want to rebuild our social contract, that's a good place to start.
So Dr. Iton, in terms of one of the aspects that is so wrong with our country in terms of our investment into social services, do you see us moving in a direction where we'll most likely get universal health care first before we start to increase, our investment in public health and social services and common sense housing and things like that?
Yeah, I mean, I hope so, quite frankly, because I think it's obviously inequitable to have people that are uninsured. And the inequity is, I think, the worst moral crime of our healthcare system and our overall system. And I think people know that. That's not actually even, it's not even really news. I mean, we've been talking about that for 50 years. But once we have everybody in, we have an incentive to make the system actually operate, to actually create health as opposed to just manage illness. And you see that incentive now in a lot of our big healthcare systems. Kaiser has that incentive. I mean, they are investing heavily in housing. For instance, they're investing in access to healthy food. You're seeing the Dignity Health system make similar types of investments because they recognize that it's in their best interest, both for their members, and Kaiser's got a third of the state, so they might as well invest in everybody because at some point they're going to be a Kaiser member. They recognize that these social determinants are ultimately the most important drivers of overall health status. And if you're in the business of health as opposed to the business of medical care, you start moving upstream. So there are some economic incentives if you're a fully vertically integrated system to move into the health business, which is really about prevention, as opposed to the medical care business, which is really about disease. We can't afford to just be in the medical care business.
Hamza asked a really interesting question. How much of these inequities, inequalities can be fought using a legal framework in the courts maybe? He's thinking about how the 13th Amendment has a clause about abolishing badges of slavery, but how it still manifests in mass incarceration in the police state, and how the 14th Amendment guarantees due process and equal protection. Narratives will help policymaking at a congressional and legislative level, but what about the judicial level?
I would argue narratives are extremely important in law. And that's particularly with this current Supreme Court, where if you read, Supreme Court opinions, they always start with a set of values, things that they say this country is about. Typically, they claim to find it in the Constitution, but if they can't find it there, they just make it up. And then that justifies their interpretation of the policy. So it's a very sophisticated question, by the way. So thank you for asking that question, whoever asked it. There are strategies, legal strategies within state courts to actually move this. There are state constitutions that you can make arguments about in terms of access to healthcare, and they can't be reviewed by the federal courts. So right now, the name of the game is staying out of federal court because the US Supreme Court has a 6-3 conservative tilt. And that conservative tilt uses a narrative of essentially, individual responsibility and small government and, the ability of corporations to be treated as people. And those are arguments that weigh heavily against things like rebuilding the social contract and universal health care.
Okay.
Looks like we're at 7:30.
Yeah, we are. And so I want to thank you, Dr. Iton, for being a continued supporter of this elective, of offering a really necessary space for conversation about how and why the US does what it does. A lot of our other sessions are talking about what this current status quo is, but not a ton of why. And this gives some of that context. We want to hear your feedback. Our feedback link is live, the same Poll Everywhere link that it always is. And thank you for being with us tonight, Dr. Iton.
Sure. Thanks, everybody. And thanks, Jenny, for keeping your camera on.
Holding it down.
Have a good night, everybody, and
Thank
good luck.
you.
All right.
Thank you.